But we do know from research that, especially the research using the perinatal grief scale, that there is not a correlation between the length of the pregnancy and the intensity and duration of the feelings that they have.
Welcome to Caring for Both, a curbside consult series by the American Associations of Pro-Life Obstetricians and Gynecologists, or APLOG. On this podcast, we bring in experts to provide insights to support you as a medical professional in your life-affirming practice and career. I'm Dr. Christina Francis, board-certified OBGYN and also CEO of APLOG, and I'm so excited to be hosting this episode today. As an OBGYN, I have the honor of being part of some of the most joyful moments in my patients' lives in the process of bringing their baby into the world. But part of my job also involves caring for patients through some of the most tragic moments of their lives. And honestly, sometimes I think this is my greatest honor, to be able to walk with patients through these tragic circumstances. One of which obviously being the loss of a child before that child can survive outside of mom. I see a great need for women's medical teams to understand evidence-based ways to care for women as they navigate the grief of pregnancy loss, both in the immediate term and in the long term. And so that's why I'm so grateful for today's guest. She really has such an amazing perspective on this, and I think is going to share some things with you all that you probably haven't thought about before or heard before. So it's my honor to welcome to the podcast today, Michaelene Fredenburg, LHD. She's president and CEO of the Institute of Reproductive Grief Care. Dr. Fredenburg is one of the world's foremost experts on pregnancy loss and reproductive grief care. She serves on the editorial board of Newborn, the official journal of the Global Newborn Society, which publishes research related to neonatology. She also founded the Institute in 2008, establishing it firmly at the forefront of creating impartial and impactful research to understand the way individuals process reproductive losses and to establish global standards for offering compassionate care. Dr. Fredenburg is the author of Change, the second edition, Making Sense of Your Own or a Loved One's Abortion Experience, as well as Hope After Loss and Grief and Abortion. Hope After Loss, and then also Grief and Abortion, Creating a Safe Place to Heal. She received her Doctor of Humane Letters from Divine Mercy University. Thank you so much, Dr. Fredenburg, for being with us today.
Well, thank you for having me.
Absolutely. So in part one, this is going to be a two-part conversation, but in part one of this conversation, we're going to be talking about how we as medical professionals deliver bad news to patients, in particular news about either a current pregnancy loss or maybe, what we might anticipate might be a pregnancy loss. You have dedicated yourself to serving those women and other patients who are impacted by reproductive grief. I'd love for you to just share how did you become interested in this and what has your career journey looked like to get you to this point? Because you are serving a very unique niche, which is why we wanted to have you on this podcast. So tell us a little bit about what brought you here.
Well, it started from a personal experience for me. This was certainly not something I had thought about or had been interested in doing, but became pregnant when I was 18, decided to terminate that pregnancy. Everyone is different, but I really, really struggled and didn't know anybody else who was. So I thought something was wrong with me. And I also really feared either judgment or people minimizing what I was going through. So I really suffered alone. When I was able to reach out, though, for help, a turning point for me was actually having the loss acknowledged and being given permission to grieve. And that started this journey of healing for me. And as often happens with that, when we begin to come to a place of more wholeness, we begin to be aware of the suffering that's around us. And it was very clear that there are so many people who are suffering alone and in silence. And I just simply didn't want that to happen. So I started by telling my story. Eventually that moved on into doing things that were thinking, okay, there actually needs to be more. There needs to be education. There needs to be research. And in time, one thing led to another. And I've always had the privilege of working with an amazing group of individuals, which culminated in forming an organization that can be dedicated to being able to research and then provide education and best practices.
That's amazing. And I think, it, I want to touch on a couple things that you said. First, I think the fact that you said that you just needed your loss to be acknowledged. And as I'm thinking in the mode of a physician, or, maybe nurses that are talking to patients in those moments, whether it be a loss through induced abortion or a loss through miscarriage. I think sometimes medical professionals might feel like they need to dehumanize that preborn child a little bit in order to minimize the patient's grief. Like maybe if I sort of, refer to it as just the pregnancy, or, pregnancy tissue, things like that. And I know we're going to get more into this, but I just wanted to point that out, what you said, because I think it is important for us as physicians and other medical professionals to acknowledge that we're not doing our patients any favors, I don't think, when we dehumanize their child. And so I just thought that was really important to point out. And then tell me a little bit before we move on to moving into really specifically what you're doing. Can you tell our audience, are all of the researchers that you've worked with, are all of them pro-life and doing this, out of the motivation of being pro-life? Or tell us a little bit about some of the other researchers that you've worked with, because I think this is to me, one of the coolest things about what you all are doing.
Yeah, well, I mean, so thinking about that, there's so many people who are potentially suffering. Certainly they're impacted. We know there's about 1 million miscarriages that occur every year. I think right now they're estimating maybe about 800 or 900,000 abortions that happen. And that's just early pregnancy loss. That's not taking into consideration stillbirth, early infant death, infertility. And it impacts both, as we know, both partners as well as family members and friends. So you have this vast amount of individuals who are there. And it's always been my determination that there should be no barriers, that we want to be able to communicate with everybody. And as an organization, we want to be able to work with the broadest group of individuals. So when the Institute of Reproductive Grief Care was founded, we don't have any religious or political affiliation. And we're looking at loss itself. And because of that, that means that we can have this really diverse group that comes together. I have to tell you, we don't ask people what their positions are on any political issue, including abortion. Our whole focus is that if we're determined to understand what people are going through, so that we can then listen and develop the best type of practices to be able to aid them in their process, that's who we want to work with.
Yeah, absolutely. And I think that's so wonderful because, there are a lot of organizations that are approaching this from, specifically a pro-life perspective, maybe working with people who would call themselves pro-life, and not that you guys aren't doing that, but I think it's just so wonderful that this is your organization, and the work that you're doing is acknowledging that every patient comes at this from their own unique position, but that women and families who experience a loss, like you said, regardless of their political stance, regardless of maybe their feelings on, say, a woman who went through an induced abortion, regardless of her feelings about abortion before she had her abortion, that you see women that are going through grief over that process and over that loss, and that you work with them as well. And so I just think that that's so wonderful. And I know through past conversations that we've had, and that I've had through some of the other mental health professionals that you have worked with, that there are researchers working in this area who would call themselves pro-choice or support abortion, rights, but also understand that many women are going through grief over this process, and we need to acknowledge that. And so I just think it's really wonderful how all encompassing your organization is, and the work that you're doing, which I think is building bridges, actually, which is amazing. So So, I think for people like me who have not experienced the loss of a child personally, yes, I've worked with patients, but I haven't gone through that myself. I think it can be difficult sometimes to imagine what must immediately be going through a woman's mind or a man's mind who's lost his child as well when they learn of this news. Can you give us some insights into that? I think that would just be really helpful as we think about how do we interact with patients who are going through this.
Right. No, it is really important. Although you've already said something that is one of the first things we always talk about, is it really emphasizing that everybody's experience is going to be unique. And so we cannot assume, we cannot make assumptions. And so that all comes into, right, that like that patient-centered approach of really being in tune with them and being able to take cues from our patients. But from research, I mean, we
Mm-hmm.
certainly can see that kind of overall, this is typically either unexpected news or maybe this is a confirmation of their fears. And either way, it can be very shocking, which means that you could be numb. There tends to be confusion. It's hard to hear. Guilt actually
Mm-hmm.
can start to set in pretty quickly, thinking that I did something wrong, or the partner did something that contributed to this. But then there's just this wide range of emotions that occurs. And even though this might not manifest itself in the moment, we begin to see pretty quickly that there's this overall sense of loss of hopes and dreams, is certainly something that's
Mm-hmm.
often talked about. This sense of failure that I wasn't able to carry this pregnancy to term. And then also this fear in time that the child is going to be forgotten. And I think it's good to
Mm-hmm.
keep that in mind because that does inform some of the things, right? We have to kind of take that mindset in when we're speaking with them. And that bad news delivery, which I know, we're kind of leaning into here, as we know, research shows it. I mean, but it's intuitive. The way it's delivered can either set the stage for a healthy grieving process, or it can actually cut that process off and create additional trauma. There's some research now, some of the scoping reviews are showing that up to 60% will suffer from anxiety, depression, or PTSD within the first 2 years after their loss.
Mm-hmm. Wow. Wow. What an what a I think unrealized impact, I guess maybe is the word I'm looking for. Um not not just on women. I know that you all work with the entire family who is experiencing grief as well, but you just think about I recently recounted to someone an experience I had with a patient who I had taken care of her with her previous delivery, which she did not lose that child, but went through a very traumatic birth and almost lost that child. And it was, things had to move very fast and that sort of thing. And it was very preterm. And the husband actually then had PTSD as well from that experience. And then I saw them in a next pregnancy, and they were actually going to lose that child actually at about 19 weeks. And one of my partners had said to me that the dad was a little bit, maybe had been a little bit verbally aggressive, with the nurses overnight, and just kind of warned me that, it's a little tense in that room. And then when I realized who they were, when I walked in the room and recognized them from their last delivery, it hit me sort of what was going on. And really all he needed me to do was just sit down with them and acknowledge that past, delivery and how traumatic it had been. And then obviously now this was even more trauma being added on top of it because now they're looking at losing this child. And but it really it got me thinking. And then you saying that, I just thought, how many patient interactions do we have that either are a little tense like that, or it's just this undealt with trauma, and that then impacts the rest of their life. And I think understanding that, and I do think that there's a tendency, probably, tell me what you think, but when we think about early losses, I think in general, a lot of people tend to sort of minimize that maybe it's not as difficult for women or even for families in general as a loss further along. Is that something you have experienced as well? Just that sort of general
Yeah.
thought towards those early
Yes,
losses?
absolutely. And I think it's understandable. I mean, from a certain point, right? But we do know from research that especially the research using the perinatal grief scale, that there is not a correlation between the length of the pregnancy
Mm,
and the intensity and duration of the feelings that they have.
yeah, yeah. That's, I think, such an important point, especially if we have, um, medical students or residents who have their career ahead of them to just understand. It took me, honestly, I mean, just being fully honest, it took me a little while in my career, I think, before that really sunk in of the depth of grief that women will feel with those early losses. Um, I think for me, or I'm sorry, what are some things that you think that we can do when we're delivering bad news that will be helpful? We're going to talk next about things that are not
Okay.
helpful, but maybe we'll give the good news first. What are some things that we should do when we are delivering bad news to patients that will help overcome maybe some of that? Like you said, the way we initially counsel is going to impact how they deal with their grief. So we want to do that in the right
Right.
way.
Well, certainly, there's been some great there's a great body of research. Dr. Brand and Butte are definitely like kind of foremost in there looking at communication, and really, it's that patient center, right, compassionate approach. So demonstrating empathy, creating space for processing, checking for understanding. So very specifically, and I think you were already describing some of that with the patient that you were
Mm,
talking about. So, what are some things you can do? First of all, not appearing rushed, making
mm,
sure that there's eye contact, especially at that point of delivering the bad news, which is really hard to do that. So, being fully present with the patient,
mhm,
perhaps sitting closer to them, really thinking about your tone of voice, if it's appropriate, compassionate touch. It's actually more of our nonverbals that are going to express even more than the things that we say to them. So, and I know that that's difficult for a provider. So it's hard to sit in that moment. It's hard to let silence
mhm,
be there. But this is actually what the patient needs. And this to them is showing
mhm,
empathy, it's showing compassion. You are validating their feelings, and helping them to process.
mhm. Wow. I'm learning things from you right now, Michaelene. Actually, I'm listening to you and thinking back to other patients that I've sat with, and I'm thinking of ways that I can improve my communication with them. So, and I'm sure others like me have also said things that were not helpful. I experienced this when my own father was diagnosed with a terminal cancer, and then all this medical information came at me, and I felt like I really couldn't process anything. What are some things that either from the research or from your own experiences that you think oftentimes are said to patients or done that are not helpful or may be actually actively harmful to patients in their grief
Right. And
experience?
certainly, as I say this, because most people don't get any education around this, and because the research is relatively new, this is not a blame type of thing. This is not at all. And I feel like
Sure.
we're all learning together. But so
Absolutely.
certainly anything that minimizes. So starting with a statement that starts with at least should not be uttered. So, please don't do this.
Okay.
Women and men do not want to hear how common this is. That this is not
Mhm.
comforting to them at all. To them, it sounds like you're minimizing what is happening to them.
Sure.
Also, uh, they did not like the word abortion for miscarriage. So, and we know that the medical term is spontaneous abortion, but they felt judged.
Mhm.
They felt shocked. They felt like, what? This is not my choice. They didn't like to see it on billing, especially if they had to interact with insurance, because they felt then again that they were judged. And then avoiding medical jargon, right? They're already confused, numb, shocked. It's hard to understand it. And then not getting overly graphic in describing, like, if the
Mm.
miscarriage is not completed. So they specifically said words like scraping, suction, parts, that
Mhm.
stayed with them. It was traumatizing. Those are things that they never forget. And this is their baby that you're talking about.
Right, right. Man, so helpful, and so many things, that as physicians, this our lingo every day that we sort of take for granted, but really watching and being sure that we're being in tune with our patients and understanding what's going to be helpful to them and what isn't. This is already so helpful, and we are just about out of time for this episode. So we are going to pick this back up, and we'll talk about in the next episode. We'll talk about some of the resources that you all have at the Institute of Reproductive Grief Care that can be so helpful to medical professionals. As well as continuing to talk about a very, I think, unique and special program that you guys have that I'm really excited about to help equip emergency departments in hospitals, because we know that this is the entry point for many women who are experiencing reproductive loss. And so I'm really excited to delve into that a little bit more. So thank you, Dr. Fredenburg, for being here with us. And we are going to pick up this conversation in part 2, talking about your emergency department training. So join us next week for that.